So I want to say hi, everyone. Thank you for joining us today. So my name is Maria. I'm a second year at Temple Med, and Jay from Temple Med and Dave from Penn State Med are part of the advocacy group in PMED's medical student section that basically aims to get medical students more engaged in advocacy work and become more informed about relevant medical policies. So tonight, we're excited to introduce you to two amazing speakers who will share their experiences in global medicine and talk about the social and cultural implications of tackling global epidemics, specifically in the context of Ebola. So before we get started, I just want to remind the audience that if you have any questions during the talk, just feel free to write them in the question box and submit them, and then the speakers will address them either during their talk or at the end where we will have 10 minutes specifically dedicated for that. So without further ado, I would like our speakers, Dr. Manish Garg and Dr. Ross Rodgers, to introduce themselves and give us an overview of their involvement with the topic.
Thanks.
Right, you want to go first?
Sure. Thanks, Ross. And before we begin, we wanted to thank the Pennsylvania Medical Society. Julie's our webinar host. Thank you very much for hosting this forum, and for David, Jay, and Maria. Thank you so much for also putting this amazing event together. And then Ross, thank you, and for our folks that are on the other side here. I see the attendees. Appreciate your time. We know that these are important issues, and it's really a privilege to be able to discuss this. So a little background about myself. We thought we would, or actually, let me give you a little overview. We thought we might talk and introduce ourselves for a period of time, and then have a discussion about this important issue, and then have time for questions. So a little bit about myself. So I am a professor in emergency medicine. I also am the Associate Residency Program Director in Emergency Medicine at Temple University Hospital. I do wear some more hats. I have also been a research director. I'm the site primary investigator for the Emerge IDNet, which is a CDC and NIH collaborative. Basically, we have different, about 10 to 15 different institutions across the country, and we're looking at emerging infectious diseases. And it's pretty cool because in my field, emergency medicine, it's nice to know that the government recognizes that it's frontline providers that are seeing emerging infectious trends. And so it's been really nice to be able to document that. And finally, in the medical school, I've been former dean and currently the director of global medicine at Temple for almost a decade. So my background with all of this is kind of at each level. So at the level of the residency program, it's been really wonderful to train future physicians and talk to them about important global issues, talk to them about compassionate care and epidemics, talk to them about infectious disease outbreaks. They've been able to help me on my research projects. Obviously, when you think about, and maybe this is a little plug for my field, but when you think about why people come to any type of healthcare provider, the two most common reasons would be pain and for infection. And if you have infection, you have pain. And so I think it's really nice to be in a field where I feel like I can not just take care of very specific patients, but take care of everybody. We talk about it as the jack of all trades, master of them all, right? And then in the medical school, it's been really wonderful to work with awesome medical students like Jay and Maria to teach them about global medicine, teach them about emerging infectious diseases, give them opportunities for service so they can do medical mission trips outside, give them the training that's necessary to be able to not just participate, but actively and importantly contribute while they're out there. And I really appreciate that awesome students don't just want to be servicing their local communities, but they want to service the world community, and they want to be global citizens, which I think is inspiring. And at the research level, it's important to have contributions to the scientific literature. It's important to be able to make consensus statements. I've been very fortunate enough to have manuscripts accepted in various infectious diseases related to sepsis and HIV and Zika and Ebola and different types of arboviruses. And I think it's important because what the medical community and the scientific community need are articles and research papers that are talking about important issues. The Ebola specific articles, because that's one of the topics for today, looked at neurological manifestations and ophthalmological manifestations basically medical manifestations that survivors had while they were out there. And then also some of the mental health manifestations like PTSD. And then finally, in my role in the dean's office, it's nice to be able to engage with delegates from other countries to work on policy, to work on service projects, to work on training trainers and teaching physicians. So I am part of a couple of different academic groups like the American College of Academic International Medicine and the World Academic Council of Emergency Medicine. And what we're trying to do is we're trying to help other doctors in other countries really develop that academic and support infrastructure. They are super smart doctors in all those countries. They don't need me to teach them the medicine. In fact, they have a lot of really great infectious disease smarts. But what I can help with is setting up systems, and I can help them with kind of like academic institutional work. And so that's the infrastructure that we can kind of create. So I'm very excited to be able to talk about our activities and events for this evening, and I'll hand it over to Ross, my colleague.
Yeah, thanks a lot, Manish. I really appreciate it. And I also second the welcome to everyone. Thank you guys for taking the time. I know we're all busy, and spending time to chat about a definitely interesting topic, and one that I think kind of on both kind of the micro scale of Ebola, but also on a broader scale of policy development and advocacy, I think is definitely needed for all of us. So a little about myself. I actually went to med school at Penn State, and then went to residency in Arizona, the University of Arizona. And I worked in the private sector for about 9 years. And during that time, I was actively involved in policy development. Prior to going to medical school, that was kind of my career. So I spent 5 years both working at the state and the federal level with health and scientific legislation and policy development for those topics that were kind of intricate to health and environmental type of research. So I had a unique opportunity when I was in Arizona. It was during the Ebola outbreak, and as the president of the Arizona College of Emergency Physicians, I was asked to sit on a CDC task force and then also the Arizona task force to try to come up with how are we going to deal with these issues. And I think for all of you, especially those interested in emergency medicine, just like Manish said, you have such a keen insight, and I think you guys will, and girls will get to know this over the time of really being on those front lines. I think you will have such amazing insight to not just patient care, but what's going on with just health policy in general for our country and for the world. And try to never lose sight of that. I think sometimes we don't realize kind of how much we know and how much sometimes the people that are making the policies don't know. So for all of you on the call, not just Ebola, but kind of like Manish said, with all kinds of infectious disease and totally many different aspects that are going to affect you on a day-to-day basis, kind of remember what an expert you guys all are going to be, and keep pushing for what you think is right. And I think tonight it'll be interesting to talk a little bit about how do we balance those kind of different type of factors that are going to create policy. And with anything, there's limited resources, and how do you put those resources kind of to the right outcomes. So Manish is by far a better expert at this than me, but I hope to give you guys a little bit of an insight into kind of maybe the how do we develop policy, how do we kind of create policy that's both favors the individual, but then also can kind of look more broad for society, and trying to come up with something that benefits both of those, I think is key. So I'd be more than happy to kind of get started, chat about issues. Obviously, it's kind of an intimate, a virtual intimate kind of group. So if anybody has questions or you want to talk about specific things, I'm sure Manish and I both would love to kind of make this interactive and make it so that we can all kind of get what we're looking for out of the next 30 or 40 minutes or so. And we both, before we joined, we both promised to get you back before tip-off. So for those of you that are watching the basketball game, we'll try to be done before the ball goes up. So we'll go back to Manish.
Awesome, Ross. Well, welcome, Erica, to the group. And so for the folks that are out there, do you have questions? Because one of the things that Ross and I both agreed was that we wanted to make sure we addressed your questions right off the bat, so that we aren't busy just having a conversation about items that weren't relevant to you. So, like, fire off questions. Like, what was it about this particular topic that made you passionate about, joining this webinar? What is it about it that you wanted to hear? What did you want to get from this? So I want you to be thinking about that as we start talking. So Ross, I had a question for you. Tell me a little bit about the policy. I'd love to, because that's something that I want to be, and I don't think you're giving yourself enough credit here. I want to do that stuff. So that you're like my hero. So tell me about that.
So I think one of the key things, and you guys have probably all heard this before, the key ways to actually be successful in policy development, especially as a physician or future physician, is to be there, to be honest with you. I think you guys have probably all heard this over and over again, but when you show up, and Manish and I can both probably give personal examples of this, but if you start showing up at meetings, PIASEP, all the different, joining the webinar, getting involved in kind of policy development groups or advocacy groups through your school, going to kind of local state meetings, people will absolutely love to hear from you. And I think that's the first step. So the first step is saying, you know what, I actually have something that I think would be beneficial. And no matter how kind of new you are in the process or how far you've been involved in this, you will always have some insight into what you've all experienced that somebody else probably doesn't. So I know that if it comes down to, or medical school debt or whatever it is, each one of you has something that you can contribute. So I think getting there is the first step. And then I think from there, it's really trying to think about we mentioned a little bit about how do you set a goal that you think will actually have a benefit for that topic. And that becomes, I think, actually one of the most interesting things, because everybody's outcome is so different. And I know when I first sat on this Ebola task force, I thought, oh, I'm an emergency physician. I think I have good insight into what we should do. And I remember there were 20 of us around the table at the first meeting. And I raised my hand and I said, oh, I think this would be a good idea. And I think 19 of us, which was basically everybody but me, said, that is horrible. So I think getting insight from other people and kind of having their perspective is also a great thing when you sit around these tables and you kind of get to learn other people's perspective. And that's the same reason I know a lot of people have bad thoughts and bad feelings sometimes against political action committees or against different groups that are always advocating for maybe one little small piece of what they think is important. But I actually think that's very, very beneficial, because sometimes without those groups or without anybody that's sitting at that table, you don't get all the different perspectives that I think are beneficial. And with any policy development, I think taking the time then to allow each of those voices, you will find that sometimes over time, you get back to sometimes the same type of things that you thought were beneficial at the very beginning. And that's kind of what happened at the Ebola. It was interesting how my first thoughts of, hey, maybe I think this is what would be good for Ebola patients, to try to maybe not have all of them come to the emergency department. I don't know if you guys remember, but back in 2013, 14, it was the goal of every single one of these patients, the first place they should go would be to the emergency department. And my thought was sometimes that may not be the best place to go. And it was kind of gasped when I said that. But at the end, it was interesting that we actually developed a policy where maybe at-risk patients shouldn't be in the emergency department. And it's neat to see that. It's neat to see how things come to fruition over time, which happens a lot, I think, with policy. Manish, you've been on the side of research. How do you think research, plays into the discussion of actual policy development? I think that's one of the things that's interesting for me. I did this before I went to medical school, and we would always, try to find the research that gets us where we want to go. So as a researcher, how do you get the actual facts to lead policy?
Yeah, that's really important. So we are living in a time of big data, and in order to make the policymakers listen, you can't, you can make an emotional plea and an emotional argument, and I think that there is definitely a space for that. One of the things that I've recently been very inspired with is in narrative medicine. I think we've been really better at capturing people's stories, but from an objective standpoint, it's important for clinicians to try to work with the public health sector in trying to get the data that's necessary for these policymakers to kind of buy in, because that's really what that's really one of the important skill sets I think that we've tried to do with some of our professional societies, is that take the information, try to turn it into a story that makes sense, use the objective data, and then try to compel different non-governmental organizations or different governmental organizations to try to enact policy or enact guidelines to help their people. And so, I mean, I can, not necessarily with Ebola, but just like with our medical students, I can give you a few examples of how we were able to do that. So we were trying to do something pretty simple. And so I think this is be relevant for the medical students that are out there. We were looking at all comers of patients in this Ghanaian population, and we were looking at hypertension and obesity. And pretty simple correlation if you think about it, like, if you have more obesity, most likely you're going to have more hypertension. But one of the trends that we found exceptionally interesting was that there were a lot more women who had higher rates of hypertension than their male counterparts. And that was not something that we had hypothesized before. And in this particular community, we found that a lot of women ended up having, they weren't getting back down to pre-pregnancy weight after they had a baby. And so they'd have the first baby, then the second baby would come, and then they would find themselves 20, 40 pounds heavier, or maybe 60 pounds heavier than when they had their first child. And so then that kind of recapitulated, and we found higher rates of hypertension. And so when we were able to make the plea to the local Ministry of Health and said, hey, regardless of whether this is a body image issue or whether this is a health issue in the particular community, we wanted to make sure that the women know that they are at higher risk for the consequences of hypertension. So the local community said, that actually makes a ton of sense. The women who we talked to, the patients, they're like, we need to do something about this. And so they kind of mobilized themselves to do exercise together, to try to make sure that they were eating more healthy, to pay attention to some of their health post-pregnancy. So, in a similar way, when we were looking at the PTSD, now we haven't been able to take our work with Ebola per se, but some of the neurologic, ophthalmologic manifestations that we wrote about in one of our first articles, and then the second article that we wrote about PTSD, which mental health illness is not something that's commonly discussed in a lot of other countries, and particularly in areas where they're concerned about insecurity in health. I think mental health issues become kind of lost on the side. And so, it's been important for us to be able to contribute to the academic literature with that. And we're hoping that we can then compel governmental organizations and non-governmental organizations to put some money and put some cause and guidelines into strategies that can help the patients in those areas. So, and one of the things that I think can be very empowering for students is these are not very, like, if you're going to make an observational study, these are not very difficult. We, some other studies that I've done with students internationally, we looked at pediatric health, the kids who have insurance versus the kids who didn't have insurance. And we used the World Health Organization growth curves for where little boys and little girls were supposed to be. And we found that if you were a boy with insurance or without insurance, you stayed pretty much on this particular growth curve. If you were a girl with insurance, you stayed on the growth curve, but if you were a girl without insurance, you were off the growth curve and you were below the 5th percentile. And what that compelled the local hospital to do in that area was to advocate for children getting on their mother's insurance and subsequently doing nutritional teaching to the patients. And these are, again, super simple studies for students to be involved in. It's just collecting demographical information, taking sequential patients. So, this can be done in a few weeks to a month's worth of time, and you can collect enough of a cohort there to be able to implement change. And you'll be surprised. I mean, the folks in other countries often are so busy that they don't even have a chance to do research and to kind of even look at what's happening. Some are able to if they have more economics, but a lot of them are not. And that's why it's really great to partner with like Researchers Without Borders and bring students who, in addition to providing clinical care, they can also have the legs to do some of the research operations, which I think is pretty special.
Yeah, I think you hit a key point to relate what you just said from the research side to the actual policy development side. And that is kind of that personal story. I think that brings so much to the table, and that's where you can do what all of you guys have. I think that you all have this unique story, and whether it's just with medical school kind of, policy development, or if it's you went overseas and you experienced exactly these kind of levels of research, how do you take what you saw and what you were a part of and then transmit that or translate that into a change? And I think that if we can be better at bringing that personal story, I think we do really, really well. So that's what I would recommend greatly. And I think that's how it personally worked a little bit with Ebola. When I was first sitting at the table with Ebola, nobody else there worked clinical shifts in the emergency department, and it was up to kind of me to say, well, what would this do when you actually are the person working that night shift, and somebody calls and says, hey, we have a high risk Ebola patient that's going to be showing up in your emergency department. And people were shocked that I said, basically, I think it would completely shut down the entire emergency department in a single coverage place for probably several hours. And I don't think people understood that. At the policy level at that time, it was such a, we need a fix right now. There's definitely some, headline type of approaches of being scared. When Manish mentioned multiple other type of kind of infections that probably were much more higher risk for all of us here in the United States. But at that time, Ebola was the headline that you had to address. And I go about that with still taking account that, all of us who are working in the emergency department, we have hundreds of other patients that we have to care for. And how do you make the system work the best? And that's kind of where I thought, well, maybe if this person is not critically ill, maybe they don't really need to come to the emergency department. Maybe we could screen them like in their own home where they don't put other people at risk. And it's I think people that have like that, a little bit of that insight into what's really going to happen at the front lines that know probably the most. So we'll let Manish play dad for a little bit, which is I've been very lucky here. My daughters have not come in yet. So, and when we got to that Ebola policy, it was interesting that there were so many things that had to be developed. You had some preparedness, you had to develop some public information, then you had to figure out how are we going to share this information. There were so many factors that were coming into play of how could we create a system that's going to work. And it's interesting when you have all of those different bodies at the table. I remember from the CEO standpoint of these hospital systems, I didn't really think about it much, but some of them said, you know what, I don't want to be an Ebola system. Like, I don't want any part of this. And that was different for me as like an emergency physician. I was thinking, oh, well, everybody's going to want to, like, we're all going to want to help this. But from a business standpoint, some of the business side of the leaders were saying, no, not here. And that may have been when you look back at 2014, and Manish probably knows, I think it was 2000, basically in the entire country. Initially we had, I think it was Nebraska and Atlanta, right? It was basically saying, hey, we're the only two right now that want to kind of step up to the plate. So that was a whole nother set of kind of the back end kind of policy development of how do we work with everybody to say who could really step up here and how do we support them from a business standpoint, not just a medical and a science standpoint, to try to kind of care for these patients. I found that part really, really kind of fascinating of, wow, this could really cripple some of these businesses that are there to try to make a profit.
Yeah, I mean, from a bioethics standpoint, Ebola is a fascinating case study. I mean, just like you mentioned, Russ, like the bottom line for a hospital is still like, it's the money, right? And so if you shut down processes for a few hours, I mean, that's it. I mean, in my training, we received the envelope that had this powder, and so a patient came up to us and was like, "Is this anthrax?" And boom, that particular zone in the emergency department was like shut down for half the day as they had to clean it up. And I think it was talcum powder. I think that's all it was. So I had a patient who came from Liberia who had fever, and thought to myself, because doing work out in the field, probably malaria, that this patient had. But they were like, "Hey, you're the infectious disease guy," and I was like, "Oh God, I want to have a hood and cover myself up because I'm going to end up having to do this."
How many gloves do I put on first? What do I do?
Right. So they, they put him in they put him in the room, and obviously it's very serious, and so we gowned up and, all the donning and duffing that's required there. So we put on our important mask. Now, we had tried all these masks out, and I helped in the process to trying to teach different strategies. And we used the folks over in Nebraska, some of their strategies on how to put on our personal protective equipment. And so then once we had like our kind of full like biohazard ET abduction outfits on, we, myself and the nurse went in. They in fact, the medical school made a point not to allow any of the medical students to care for any patient who had suspected Ebola. Similarly, the residency, the GME programs also did not allow any residents to take care of that. So it really came to the attendings, and so it was me and one nurse. And I got to tell you, the actual outfit, the mask was so hot that the nurse started to get faint. And so after she was like, "I can't do this anymore," after about 10 to 15 minutes, it was me. And I had to tell you, like after that, it took, for the single patient, it took probably about 2 to 3 hours of me working. And now, yes, I have colleagues working in other departments within the emergency department, but that really did put us back. I came back and there was about 20 to 30 people in the waiting room after, just being gone for that period of time and like stopping the flow and then stopping that part of the zone. And thankfully, after all the lab testing came back, it ended up being malaria. But, that there's an example where, obviously the person, they're scared, the hospital is scared. We really got a crash course in the kind of chain of custody of keeping of all of the materials because everything had to be disposed of properly. And one of my trainees who did some work with an international organization, Colin Bucks, he actually did one of the videos. He was out there in Liberia taking care of patients. And, I bless him for doing that. I think it was amazing. It was something that I wanted to do, to go out there, but I had some certainly real fears to be participating, certainly with a family. But, I kind of felt like there was a moral cause and a responsibility to try to help out in that part of the world. And one of our attendings had gone to Liberia and helped out at the JFK hospital that was there, and was friendly with one of the physicians who passed away from Ebola, who contracted it. So one of the first doctors who died from Ebola when it first kind of hit that area. And it's crippling. There weren't that many physicians to begin with in the country, and then to lose one. I mean, it's a really horrible. Any process that has like an 80% case fatality rate, and you just don't know what's going to happen. And there's so much unpredictability that happens in medicine when you're caring for patients. So, I mean, anyway, it was it was pretty harrowing. And, for that tiny little slice, we dealt with what wasn't even the real thing. And, for my colleagues who've been able to help patients with the real thing, it's, bless them for doing that work.
No, I agree. I've had one suspected case, and it really brought our hospital to a halt. And it really, you're right. All of a sudden, all of the little training things that you've done, it means so much. In our case, turned out to be negative too. But at that moment, you're really there on the front lines. And I was thinking of the same thing. I was thinking of the people who are actually on the front lines in Western Africa who have dealt with many, many deaths and many, many kind of real cases. Those people, obviously, that calling that they have, I think is amazing for overall global health.
Dr. Garg, we have a question for you. You talked briefly. You talked briefly in the beginning about mental health. So the question that came in was, could you elaborate more about what you saw as the mental health impacts on both patients and providers at home and abroad?
Yeah, absolutely. So, one of the things that having a context of insecurity, having a culture of fear that surrounds you, having loved ones die left and right, having your normal institutional, areas kind of crumbled, all of that contributes to that context of insecurity. And so our patients, what we really looked at was post-traumatic stress disorder. And these were like long lasting. And so if you define it, you use that diagnostic statistical manual criteria, there's a few different elements that come out. And what happens is folks tend to relive that horrible experience. They tend to avoid, and they tend to be like hypervigilant. And that amount of both mental stress as well as physical and somatic stress that kind of comes from that, it's really terrible. And there were high levels that persisted in those regions, right? Because folks continually think about how their loved ones passed. They think about the fact that they may not still be safe while they're there. And even after there's technically like a, quarantine or everything's safe, there's still a long sense of a context of insecurity. Some of the med students recently, as part of Temple, recently went to to Puerto Rico that got hit by Hurricane Maria. And, even 6 months afterwards and even a year later afterwards, there was a huge context of insecurity and folks that were depressed and folks that were contemplating, depression to suicide, all because of this horrible catastrophic event. So imagine you've got the catastrophic event and you are seeing so much mortality and morbidity around you. It's a lot for folks to process. And then that's the patients and that's the folks that live there, even in the healthcare providers that were caring for those patients. I mean, we're talking about the same levels of folks that are dealing, like our armed forces folks that are dealing in wartime situations. They are seeing such horrific images and carnage, and they're a part of it, that depersonalization becomes a reality. And so, those are some of and that's just like a small, obviously you've got, mood order access. So depression, suicide, you've got the PTSD access, you've got the anxiety access. All of those become real aspects to this. That's why we try to make a culture of support within our medical school, within our residency programs, because the work that we do is tough. And it's hard for people to really understand what it is that you go through on a day-to-day basis. And we see some pretty crazy things.
Yeah, I think that's very heartfelt. I think that's on both sides of the coin. From the physician standpoint, what you guys and girls do every single day is really amazing, I think, to just the common person. And as you move through this more and more in your careers, you'll understand that it's incredible what you will do every single day and how outside the norm it is, I think, for the common man and common woman. And I think that was another question kind of by Nate was, well, how do you disseminate, or how do you try to get the information out there for something that's a devastating disease, but also try to not just create complete panic,
Yes.
basically like the movies, Outbreak would do. And I'm sure Dr. Garg saw that. We saw that a lot at our hospital. We had many patients showing up every day who had zero risk, or at least real risk. Their perceived risk was there, to the fact where they thought, oh, I think I was standing next to somebody who had been to Africa, and I think that they had a fever. I was told they had a fever. I need to get checked for Ebola. And at our hospitals, during the kind of the heightened phase of Ebola, we would have at least 5 to 10 patients that just check up and want to be tested. Yeah. And it's a great question of how do you try to make sure that the information you're delivering is real? How do you try to make sure that you don't just kind of blow off what's happening? Because the epicenter of where this was going on in West Africa, I mean, it is very, very real. I think for me at the time in Arizona, the risk was pretty low, but it's still a very high perceived risk, I think, for the patients. So I think to Nate's point is the key thing is, I think you have to really, really, really try to provide just kind of factual information that gives patients their real risk. And what is really going to be kind of the outcomes of what we need to do as far as at that level of risk.
It's nice to see too, like the physicians who are medical correspondents, I think they try to use data and they try to like make a real point there. And it's been nice to see that they are kind of taking that banner and that cause, because as we know, the sensationalism of the media, I mean, they are great at what they do, but sometimes, obviously, in order to get their clicks and to get their audience, they will also, popularize and sensationalize things to the point where, I mean, I'm sure you remember, Russ. I mean, when it was the, swine flu time, right? Then, all folks came in with the swine flu. Back in my training, in addition to the anthrax, that was also the time of West Nile virus. So I had folks coming in, well, I got bit by a mosquito, so I must have West Nile virus, and SARS and Zika. So it's all of these different things. They have to be, the messaging has to be like in a real zone, as opposed to like, a little too much or a little too little, right? It has to be like the Goldilocks, it has to be just right.
And I think we have some ownership in that.
Right.
I think we all do that too. We could all push. If Ebola is the hot topic, well, let's push for as much kind of Ebola research or Ebola money, or, how do we try to get grants to these things? And sometimes I think it was beneficial for us to step back and say, well, we have a lot of other things going. We have influenza. We have a lot of other type of disease processes that are probably more real and more important. How do we blend those two things together and come with that just right amount? Because if you just went 100% of all of our funding, which at the time, like DHS was like, we got to go all in on this. But some people were taking a step back and saying, well, just wait a minute. Like, let's not give up every single program we have just to put it all towards Ebola, when that may not be our best bang for our buck. It would be nice to do everything, but as we all know, that doesn't happen. So how do you find that just right amount to, I think, benefit society the best? It's tough.
Yeah, and it's nice to see some of our benefactors, like Gates went after malaria, and that there's an example of something that really doesn't affect us at all in this country. It's really the travelers who go out and then come back where we're seeing malaria. But internationally, it's one of the top infectious disease causes of death. And so it's really great to see all the research and money and energy that they put in, and then the fact that they're working on a vaccine there, which I think is tremendous.
Speaking of vaccines, what do you think of the Ebola vaccines? You think we're getting close to?
I think we could. I think so. I mean, it seems like it was effective in the patients that were able to receive it. So
I think I heard something. It was from tens of thousands. I think 10,000 about deaths during the kind of the first big outbreak to less than 50. I think really with a similar type of outbreak. So hope that's just a huge key point to research is, if we don't put in the finances and if we don't put in the resources to try to stop some of these issues, we won't get the great benefit from it.
Yeah, you talked about outbreaks. So another movie, Contagion,
Yeah.
right? Had all of that showed how quickly the world could get infected by a particular vector. In that case, the Nipah virus. Interestingly, we're going to send a team of students for the summer to a part of India, and right before we went there, we found out they had an outbreak of the Nipah virus.
Wow.
And so, yeah, our host site there was like, I don't know if it's a good idea for, to come. And so thankfully, we had set up a hub and spoke model. And so another one of the spokes was able to host the students for that year. And so they're able to take, and then amazingly, like the government in that section of India completely contained it. So after they learned from lessons of Ebola, they were able to, they were really able to make some amazing differences. And I think they had such few mortality, it was considered like a real like triumph in disaster preparedness.
Yeah, that's amazing.
Any other questions? We're kind of coming to the almost 10-minute mark here.
Yeah, Dr. Garg, we have another one for you.
Okay.
Could you please elaborate more on what you were saying about narrative medicine earlier?
Yeah, absolutely. Thanks, David. I think one of the real ways that students can get involved is when they do go out, and whether it's a service experience or a research experience or an academic, maybe teaching experience, all of which are really, really wonderful endeavors when they're going internationally, there are so many stories to tell because, we learn through stories, we learn through narratives. I mean, the best way that I could ever teach anybody anything is through stories. And I actually have like a 3-part way that I teach people things. I give people, whatever the pearl is, the educational pearl. The second thing I do is I teach them approach to that pearl. And then the final thing I do is I teach them a story that they'll never forget. And it's always the story. And I have a lot of my trainees come back and go, hey, I remember that one time you told me that one story, and it's like stuck with me. So I've been on a couple occasions, I've had students put together pieces that they've done internationally, and these international pieces that they've been able to do, one of them was at was a really heartful story about how a student felt both engaged yet simultaneously powerless working at a Greece refugee camp. And so with the big Syrian transmigration, she just told the story of what she was feeling at the time. And I told her I'd be happy to review it. I looked it over. It was amazing. And, I tried to help her kind of say, is this the message that you want? And so I'm hoping that soon she gets that published. Had another student who did get one of her stories published. So it's an opportunity for your voice to be heard, and many different academic journals are accepting these now for publication. So it's a real way that anybody can do it. And now there are places that are doing story slams. So I'm proud to say that Temple is one of the places where we've had story slams done, and people come and share their different stories, whether it's locally or internationally. And it's such a well-received concept and idea.
Yeah, I would second that a little bit. I think from a medical student perspective, I think narrative medicine can put those, I don't know if it's the right term, but I call them almost like mental models. I think as you work your way through, especially your clinical years, on those patients, really take a minute to kind of put all those senses together. What was the patient's name? Where did you see them? Like, what was their story that relates to then that disease process? And I agree with Dr. Garg. I think that, to me, when we go through our emergency medicine rotation, that's what the students remember. They will remember the patient, as I just had an email earlier tonight about a student that saw a patient where every kind of aspect about how she described her presentation and how she kind of looked and felt and all the different things, kind of the emotion that's there, is what will make you remember, instead of really the disease process. I think the disease process is kind of so cold, but now I think with that case that she just experienced, she'll probably remember that forever because there's a person kind of associated with it. And I think you can bring that to your own education. You can bring that to international medicine. You can bring that to policy development. I agree with Dr. Garg 100%. It's those stories, and it's that mental model that we make of those stories that will kind of make your career, because our lives it's about the lives that we involve, not really the diseases, I think, that we see.
Mm-hmm. So for our students, that's like, I think, a really good segue about different ways that, I think that you could get involved in this particular topic. So, at a medical school level, we would encourage you to join your international health organization if you have a disaster medicine interest group. These are ways that I think will be important. I think if you can identify the folks that are doing international work, it'd be nice to try to, shadow them in their, real clinical work. It'd be nice to have them come, give lectures. I mean, I haven't met a physician who doesn't like to talk about what they do internationally. So, I think that's like a really easy way to get the conversation started. I think that joining your local either state chapter, just like our Pennsylvania Medical Society, or a professional society that you think might help you get some tools, introduce you to mentors who are interested in the field. I think it's important to try to find symposiums that are local. I'm going to make a tiny little plug. Like if you're in our particular area, Temple's hosting a World Congress on Academic International Medicine this summer, July 26th to 28th. Their students will be able to present stories if they want for narrative medicine related to their global endeavors, in addition to meeting folks. And so lots of opportunities. You just have to find them, search them out. I know, Ross, you could talk about it at the policy level. I agree with you, just showing up. And then do those service experiences, whether it's service, whether it's research, whether you're going out to going to one of these academic teaching conferences. They are all valuable. And every single time that you go out there, it plants a little bit more of a seed, and you can see a little bit more of what you're able to accomplish. It's kind of like Inception. It's just that idea that gets in your head, and it builds and it builds and it builds. And then it really can germinate. And as you kind of get more and farther along in your career, you can really, really do more and more special things. That's how I did it.
I think that's perfect. Any other last minute thoughts, questions? I think the folks on the call, I think you guys are doing what's right. I think you're getting involved. Get involved at the med student level, then get involved at the resident level. You'll be, I think, amazed how easy it is to kind of find what you want to do and make a difference.
Yeah, and you can create it too. You can create, if you become the champion for global medicine at your area, like whatever your shop is, you can do that. You get the speakers, you go on the trips, you find the person who represents the heartbeat for that. And, there are so many fellowships at the resident level that are, unfilled. So if that's, what your passion is, you're able to do that. There's so many parts of the world and deserving patient populations that need your help. So, it's a really, really, not just hot time, but it's a really, I think, meaningful time. And like, you can kind of fulfill that social justice kind of advocacy that I think we all are very passionate about.
Perfect. Any other thoughts from those on the call?
So I wanted to say thank you to our group. And, I don't know if there was any closing from our student hosts that you had pre-prepared. If not, I just called you out. I'm sorry.
You have one now.
I think we're getting ready to wrap this up. So first, we'd just like to thank the speakers, Dr. Garg and Dr. Rodgers, for your time and wonderful insight. And we'd like to thank the audience for your questions and participation. We'd like to point you to the PAMed website for future events and related to advocacy. In the immediate future, on April 14th, we have a personal statement writing workshop, but there's all sorts of events we have, and it's very easy and fulfilling to get involved. And of course, please join the Congress that Dr. Garg was speaking about in July.
Yeah, and
I will have just returned from Ghana. Maybe I'll come give a little story.
hey, Ross, I would absolutely love for you to come speak.
Yeah, that'd be awesome.
We have
Yeah,
an
2 weeks in
institutional
Ghana.
panel group, and I'd love to have the Penn State folks there. And I mean, maybe some final thoughts for our attendees. Listen, one of the things that I have to deal with on a almost day in and day out basis is trying to show the C-suite and the hospital and the medical school leadership that awesome medical students can do anything. And if we give you the tools and empower you, you guys can move mountains. And I have been blown away by what the students have been able to accomplish. So, you know, I just feel so excited and happy to see what the students are like capable of. And it makes me very excited to know that as I am able to kind of pass the torch of all the things that I'm able to do, I know our future is going to be great because of students like the folks who are running this conference, like the folks who are attending. And, you know, and I hope my kids can be inspired and grow up and be just like you guys. So thank you.
Very well said. That was way better than one shining moment.
You want me to sing?
That was way better. Way better. I like it. That was the international one shining moment. That was perfect.
All right. Thanks.
I hope you all have a wonderful evening, and keep in touch. I'm sure that you can get in touch with either one of us. We'd be happy to help you, get you in the right contact of whatever you kind of want to do. I think that's another thing, is just use all of those avenues to get where you want to go. That's what we're all here for. People did it for us. And I'm more than happy to try to get you guys all where you want to go.
Pay it forward.
Yep.